Next, we have our guest speaker, Dr. Sumitha Agarkar, madam. She's talking on two things. One thing is atropine myopia, the present status, and also back to back, she will be talking on myopia controlled glasses as well. Over to you, madam.
Thank you so much. Thank you to organizers of KSOS for inviting me. And I always enjoy coming to this meeting because usually there are lots of questions asked and people are interested in listening to what we have to say. Thank you. So atropine is not really new. The first atropine studies, first recruitment for atropine studies was way back in 2004. So we have now probably a cumulative evidence of how atropine is working for past 20 years. And why are we still talking about it? Because it is an increasing prevalence. And if you see India somewhere here, there has been from 6% prevalence in 2003, we are touching around 25% in India, and that is not even accounting for COVID years. So in 2010 to 2050, there is a massive increase, and it is projected that 48.3% children are likely to be myopic by 2050, which is a alarming figure. If you look at the so this is our data. This is a STEM Shankar Netralaya STEM Tamil Nadu SLR study, and we found almost 25% children, 17.5% in urban and suburban children in Tamil Nadu were myopic, which is a huge increase from our own school data earlier. So like winter is coming, myopia is coming. And why it is important to, because myopia is not just spectacle alone. If it was just spectacle alone, we really shouldn't bother. Okay, we give spectacle and that's the end of the story. But myopia also comes with an increased risk of complications like myopic maculopathy, glaucoma and retinal detachment, and the risk increases from as there is a dioptric change. As you can see, maculopathy risk is around 2.2, which increases to 9.7, and if it is more than 6 diopter, there is a huge increase in the patient's probability of patients developing maculopathy. Same goes for retinal detachment, both of which are visually disabling condition and require a huge amount of expert care, as well as economics is also daunting managing these conditions. That's why every diopter counts. However, when we look at myopia control options, it's important to remember we are treating progression and not myopia. So everything is designed to look and control progression and not really the myopia. Myopia correction is still, treatment is still giving a pair of glasses, but if the progression is there, you should probably target, your target should be the progression and not really the myopia. So who needs intervention? Generally, any progression of 0.5 diopter or more over a year, if you see, then I think you should look at it. Axial length elongation of 0.1 millimeter or more, because most of the complications of myopia are related to how long the eye is. So axial length elongation also becomes a part of your myopia workup, not just cycloplegic refraction. And also you have to look more carefully at children who are at risk of progression, like if there is a parental history, lifestyle, sleep patterns, these should be included in your algorithm about deciding who needs progression, who needs intervention. So these are all the things which are available at us for us to use. You have pharmacological agents, you have optical devices, you have specialty contact lenses, you have combinations. But most important, and we don't talk about enough, is lifestyle modifications, which we should take 2 minutes of chair time to explain about these. So these are the pharmacological agents, and my talk is on myopia. So apart from atropine, I'm not going to talk about rest of the two because they are theoretically they are effective, not so much 7-methylxanthine, but pirenzepine, but they are neither available nor they are applied to our country per se. So initially, effect of myopia on atropine on myopia was supposed to be an effect on accommodation, but now we most likely postulated mechanism is that its effect on modulation of the dopamine release. It functions at a relatively low dose via a neurochemical cascade, which begins and at M1 1 to 4 receptors in retinal hemacrine cells. So what atropine does is it binds to these hemacrine cell receptors, leading to a release of dopamine, which acts like an inhibitory influence on the elongation of the eye. It is postulated that atropine can also have a direct influence directly on scleral fibroblasts and interfere with the scleral remodeling associated with progressive myopia. So direct effect on sclera by inhibiting glycosamine glycan synthesis via a non-muscarinic mechanism is also postulated. Now important thing to remember is that despite all these postulated mechanisms, we still have a slight gap in knowledge about what atropine is actually doing and whether this has any long-term effect on these children, which is visible 30 years down the line or 40 years down the line. There is a little gap in knowledge here about exact mechanism of action. How effective is the atropine? Well, we may think that atropine started with ATOM studies, but actually the earliest studies using atropine were way back in 70s and 80s. And the first two randomized control studies had already demonstrated, which I have mentioned here, had already demonstrated a 60% or more decrease in the reduction. But these trials were often not gained traction because one, there were a lot of dropouts, and second, there was never a control group in these studies. So despite hype about myopia after atropine, but actually people were looking on this the work had started much earlier. Then of course came ATOM-1 and ATOM-2, which were much better designed trials because they were randomized, they were prospective, and they had a control trial, they had a controls. So they included 400 children, and myopia of 1 to 6 diopters, and ATOM-1 looked at the efficacy of atropine versus placebo, which was and other eye was used as control in ATOM-1, and you could see that there was a spherical equivalent in eyes which progression was around 0.3 diopters compared to 1.2 diopters in the non-placebo eye. Now, so they wanted to look at the lower concentration because 1% atropine, though effective, was also associated with pupillary dilation, loss of accommodation, and photophobia. So ATOM-2 looked at the efficacy of lower percentage atropine or lower dose atropine, as we know, and again controls were again historic controls, and corresponding change in the spherical equivalent was around 0.3, 0.4 and 0.5 again. So efficiency was atropine. These studies did prove that efficiency of the atropine was clearly dose dependent, and LAMP study also said the same thing. A LAMP study looked at 0.01, 0.2 and 0.5, and again 0.05 worked the best on best control of progression. And it is also a LAMP study, since there was a washout period, it also showed that progression is again seen after cessation of the treatment, and like efficacy, even the rebound is related to the how strong dose you are using. So what did we learn? That yes, it is dose dependent, rebound on cessation, which is also dose dependent, pupillary dilatation was least with 0.01%, and effect of near activities and accommodation was also less. So that's how we came to this magic number of 0.01%, because it was efficacy wise equivalent but had other less co-issues which were there. Now data from India, there was an IATOM study, which was a multicentric placebo controlled prospective study, again 100 children, and a mean increase in myopia group was 0.616 versus 0.35 in placebo. ATOM-2, which was IATOM-2, or the second larger retrospective study, which looked at 2 years result, and this study was much larger with different 20 centers and more than 700 patients were enrolled. And again, mean myopia progression with atropine was much less compared to those who did not, in this study there was no control group, but you could see that myopia progression did reduce at the end of 1 year with atropine. This study also identified that younger children who had received atropine or who had myopia earlier had higher baseline progression and poorer response to the treatment. However, the only one limitation with this study was there was no analysis on the axial length effect of atropine on axial length in India. But still, there is enough evidence to show that atropine does work. Is it universally? No. Well, some 2 studies from USA at the same time showed almost a different result. One CHAM study showed good response, while Repka et al. Have reported that there was not at all effective in the study. But probably there are racial differences and so what about non-responders? So 10 to 15 children are children are likely to be non-responders. However, wait for a year before you label them as non-responders. Options are either doubling the dose or concentration. You can shift to a combination with the myopia control glass or another modality, or you can shift them all over to the different modality, like shifting them from atropine to glasses or ortho-K lenses. Who are most likely to not respond? Who are most likely to respond to atropine, low dose atropine? Slightly older children, and children who do not show progression in the first visit itself probably are going to be likely to show better response to atropine, and you should probably continue atropine for them longer. Pre-myopia, is there a role? Well, Hong Kong studies have and our own Dr. Jethani has also published efficacy of low-dose atropine in preventing progression of myopia in children who are not yet myopes but who are low hyperopes for their age, typically the siblings of children. So if you can motivate the parents to get their axial length and you do see a elongation of the axial length or a decrease in their hyperopia over a period of a year, you can look at atropine. There is some evidence that it may delay the onset of myopia. So if you look at the evidence, it is effective, economical, can work across powers and ages, easily available, and dose strength can be titrated because now we have 0.05 also very likely to be available in India, waiting for DGCI clearance. Is it everything hunky-dory? No, not really. There is some sobering data from patients who subjects who participated in the original ATOM study, which is 20 years back, who are now in their adults. So they went back and looked at those adults now who were enrolled in ATOM 1 and ATOM 2, and they could not examine all patients who were enrolled in those studies, but fair number. And there was no difference in spherical equivalent or axial length in eyes treated with placebo or atropine. This is a little bit sobering data. But remember, those children received atropine only for 2 years and no more than. So all this study, even though it was not sufficiently powered, what it tells is that rebound is definitely catches up. So 2 years is not sufficient, what ATOM 1 or ATOM 2 or what we tend to believe looking at the evidence. Similarly, there was no change in the incidence of myopic macular degeneration or retinal detachment. So was it really successful? This study did not look at with sufficiently powered or all patients. There are problems with the study, but what it does show is that even though you put atropine, you are likely to require it for longer years, and you probably have to think that at some point when you stop, there is going to be a little bit of rebound. And these children, even if they are less myopic than what they would have otherwise, they still need care and attention later on also. Thank you so much for your attention. So this is all I have for atropine at this